There's unintended misuse of the code that happens occasionally, but then when there's intended use, then that's a pattern. And then, oh boy, you better know a lawyer.
Yeah, exactly.
And there
Yeah.
are dental insurance lawyers that focus on this, unfortunately. So if you
Yeah.
ever get a
Yeah.
chance to listen to any that come your way, if you're not in California, if you ever hear a dental insurance lawyer give a talk, you got
Yeah.
to listen, because it's crazy the fines that they. I remember talking to this one, and he was saying just the amount, it was like, I want to say $300,000 in just PAs,
Oh
just the
man. Yeah.
x-rays,
Yeah.
because they were not of diagnostic quality. They were,
Yeah.
open bites, overlap, all that
Hmm.
kind of stuff. And then there was also being charging for it. And although it's there's nothing in the documentation that it was read. And so
Yeah.
just hundreds of thousands of dollars just on PAs.
Yeah.
So, and I remember thinking, you should be happy that they stopped at PAs. Like, they could have gone to bite
Exactly.
wings. They could have gone to
Yeah. Yeah.
FMXs.
Yeah.
Oh my gosh.
Diagnostic quality x-rays, really, we see those pop up in audits all of the time when, they're looking at the x-rays and I have to explain to the doctor, well, you submitted for this, but it's really not diagnostic quality. So,
Mm-hmm. Mm-hmm. And
and
they're like, well, we took it. So, but
exactly. Sure you
that
did. Yeah.
doesn't
Yeah.
mean
Yeah.
anything. And
Exactly. Yeah.
I've been saying in classes, I don't think you need to worry about what the insurance carrier thinks of your x-ray. Like, that's the least of my concerns. You have to worry, will a judge or a jury take a look at this x-ray and say, why did you do that? Like, if you take an x-ray to that level, the insurance carriers are going to be fine. But so diagnostic quality, let's just kind of brainstorm this real quick. So clear, able to read,
Hmm.
accurately shows what it's like. If it's a PA, it shows the
Exactly.
apex and everything.
Apex.
Bite
Yeah.
wing
Or
shows
no
ground
cone
surfaces.
cuts. Cone cuts. Oh my gosh. Cone cuts. Yeah.
Mm-hmm.
Cone cuts.
Yeah.
Yeah.
And
Yeah.
even the exposure level,
Oh, sure. Yeah.
the
Yeah.
film. So if you've got a staff member that takes terrible x-rays, like, that's not
Yeah.
okay. You got to
Yeah.
correct that.
And
Yeah.
I think digital x-rays have really helped quite a bit in the last several years, being able to take care of some of those things. But,
Mm-hmm.
again, if the image is too dark, if the image is too light, if there's a cone cut, if it's, yeah.
It's pretty exciting what they're doing, though, like being able to show the patient on the AI image, like where it
Hmm.
is, like they can totally see it.
Yeah.
One thing that the consultant carriers have been telling me is that if you're going to send in an AI enhanced image, you have to send in the original. You can't just send in the AI enhanced
Ah,
image. They want to see the original
got
and
it.
then the AI. And then here's what's interesting too is the doctor, the provider is going to take a look at that and maybe annotate it, mark it up. So they'll send the
Hmm.
original, send the marked up one. The carrier has their own AI that's going to evaluate the image
The
too.
original. Yeah.
So
Yeah.
I would love to see what they come up with. Like, I don't know if we're ever going to see that on the provider's end, but I would love to see
Sure.
what the carriers come up with. They also are going to run the AI on that original image, and it'll be interesting to see, like,
That would be a fun little project. Yeah.
yeah, I'm curious
Yeah.
about that. And then
Yeah.
they're looking to be able to show bone level, have the
Mm,
AI just do kind of a visual
yeah.
representation of bone level. That's like, wow, Lisa, when you and I started, did you even imagine like all of this?
I talk quite often to offices that have their scaling and route planning denied. When I first started, we just sent in a perio chart with the numbers on it. We didn't even mark bleeding. We didn't mark anything else. And so
Mm-hmm.
now, because it's been such an overdiagnosed procedure, that there's some guide rails on it now. So it makes it a
Yeah.
little bit interesting. It's nice to see some protections put in place for patients, but also on the other hand, too, it's making our documentation a little bit better.
Yeah. Well, and I don't think that's a bad thing, right? So
No, no, yeah.
So talk to me about what the questions are around SRP and what is the most common pain point that you're hearing other than it not getting covered.
Yeah,
Like, what is
yeah.
it? What is it about it not being covered?
I think the biggest issue they get is they think that it's just 4 millimeters across the board for every plan, and it's not always the case. Some
Mm-hmm.
plans are wanting, 5 millimeter or greater pockets. So I understand from a doctor standpoint what the correct procedure is to be done, but I have to always talk to them and say it just doesn't necessarily mean the plan is going to consider it covered. So,
Mm-hmm. Mm-hmm.
it's not just 4 millimeters across the board anymore. There's a lot of things that go into place for it.
Would you like to hear more? Follow the link for the full episode.